space between the visceral and parietal fluid is called the pleural space or cavity, and normally contains only about 2 to 5 milliliters of fluid. Normally, several hundred milliliters of pleural fluid are produced and reabsorbed each day. Fluid is produced primarily at the parietal pleura from the pulmonary capillary bed and is resorbed both at the visceral pleura and by lymphatic drainage through the parietal pleura. The pleural effusions are divided into transudate or exudates depending on their protein content and their lactate dehydrogenase concentration. Transudates tend to form when there is increased capillary hydrostatic pressure or decreased osmotic pressure, and their cause includes congestive heart failure, which is the most common cause of transudative pleural effusion. Also hypoalbuminemia, cirrhosis, nephrotic syndrome, and exudates tend to be the result of inflammation. The most common cause of an exudative pleural effusion is malignancy. An angioedema is an exudate containing pus in a hemothorax. The fluid has hematocrit that is more than 50% of the blood hematocrit, and chylothorax contains increased triglycerides and cholesterol, and certain diseases tend to produce pleural effusions in one hemithorax or the other, or in both. So whether if it is bilateral, mostly it is due to congestive heart failure or lupus erythematosus on either side, but usually unilateral, that is due to tuberculosis, pulmonary trauma, aortic disease, and trauma. And left-sided is due to pancreatitis, distal thoracic duct obstruction, Dressler syndrome, and right-sided is due to rheumatoid arthritis or proximal thoracic duct obstruction. And pleural effusion on X-rays, as the subpulmonic effusion grows in size, it first fills and thus blunts the posterior costophrenic sulcus, which is visible on lateral or frontal chest X-rays. Posterior costophrenic angle or sulcus is visible on lateral or frontal chest X-rays.
Lateral.
So, if there is small amount of fluid accumulation in the costophrenic angles, you would be able to see it on frontal or lateral chest X-rays.
On the both you can see, I guess. Mostly on the lateral, but we can also see on frontal as well.
If it is small amount, you will see on lateral chest X-rays. If it is more than 300
okay, on the frontal as well.
Then you would be able to see on frontal chest X-rays. So on lateral chest X-rays, you can see up to 75 milliliters of fluid. On frontal chest X-rays, the ossification that is produced due to the pleural effusion is called meniscus sign. On lateral chest X-rays, it would be called U-shaped opacity. So this is U-shape, and this one is meniscus. False. Pleural thickening caused by fibrosis can also produce blunting of the costophrenic angle. The solution is scarring sometimes produces characteristic ski slope appearance of blunting, unlike the meniscoid appearance of pleural effusion. And here you can see that ski slope sign. And below it, what is this?
Spleen? Organ, but it's all, I guess, organ. Konta organ hai? What is that?
Airfield problem. Large problem. patient is in the upright position, pleural fluid fills to the base of the thoracic cavity because of the force of gravity. And when the patient is in the supine position, the same free flowing effusion will layer along the posterior pleural space and produce a homogeneous haze over the entire hemithorax. So scarring due to, for example, previous infection, surgery, or blood in the pleural space produces a ski slope sign. An effusion typically ascends more laterally. That's why we have this meniscus sign, lateral to chest extension. And this is the supine position of the patient who has right-sided hemithorax filled with pleural effusion. What can you see here? What type of examination is this?
This is CT.
Which projection of view is this?
Axial.
Axis. Which window is this?
Which one is this? No, sorry.
What type of windows do you remember? Soft tissue.
What's your bones are
Bone
classic.
window and
Soft tissue from window.
lung window.
Okay.
So which window is this?
Bone.
No.
No. Lungs. Lungs are black.
No.
More black.
Okay, what can you see abnormal on this CT scan?
Yeah. सर
What is this?
तेज खून का है
Hmm? Right side, left side.
left side.
Is this left?
Left side, left side. Yes.
Is this left one? Is this left side?
Right side, the heart is.
So then,
This is right side. Your right side is the patient's left side. Your left side is the patient's right side. So this is your left side,
तीन
patient's
साथ
right side.
पूरा टाइम बैक इधर.
What is this? This is the heart surface. And it is marked. What is this? What is this?
That is ma'am, but how it is left right side? Because the outside we are seeing this vertebra, right? So back side this is vertebra.
This is vertebra.
Okay. So then this should be the right, this should be the left, no?
Your right side is the patient's left side.
But the section is this axial, right?
Okay, imagine I'm lying here
Mm-hmm.
and you cut me through this
Yes.
and look at me. This side would be my
Left side. Right.
right side.
कसं काय?
You look at the patient from
बरोबर
big
की.
to
वरून नको बोलू, खाली नको. Understood. काही समजे नाही. No, but at home I will understand.
The
Okay.
easiest to look the heart position. Heart
Yes.
is more to the left side.
But in city we will not see every time heart.
every
Ah,
slice.
because
Remember,
Yeah, this is
heart
missing.
level will be
you are
not always
looking
present
at the
as.
patient from feet to heart.
It's
But I
still
always saw for the vertebra now.
But it's still mirror image now.
Mm-hmm.
In mirror it will be opposite.
The only image that is not covered is the fluoroscopy images.
Fluoroscopy.
Yes.
Because you're watching live
Ah,
and when you get the X-ray image,
is effusion. No? Pleural effusion. No?
If the patient is lying on his neck, the diffusion will be
That will go down.
posterior.
Yes.
So where is the diffusion here?
So that one below to that black. Yes.
Is there effusion on the left side?
Sorry, no.
No.
But that one, that's this one. Yes. Yes. And what is that one?
This is the diaphragm.
Hmm?
Right.
Which one?
And below the diaphragm, you will be able to see.
So what was that white
So
opposite?
there is bilateral
Effusion.
So would you be able to see this quantity of effusion on X-rays?
No. It is slow, less than that,
Left
right?
one for sure you
Yes.
would miss,
Mhm.
but right
Right,
one it
might be.
okay.
Right leg मध्ये स्पॉन्डल होते.
So when the hemithorax of an adult contains about 2 liters of fluid, the entire hemithorax will be opacified. And as fluid fills the pleural spaces, the lung tends to undergo passive collapse or atelectasis. Large effusions are sufficiently opaque on conventional chest radiographs so as to envelop and mask whatever disease may be present in the lung. CT is the modality usually employed to visualize the underlying lung, which is rendered impenetrable by large effusion. And what can you see on the first image on X-ray and on CT? Let's start from the X-ray.
Effusion.
Effusion. Ossification or lucency? Right or left?
This is left, right? This is right.
Left, okay. Ossification or lucency?
Okay, opacification obviously.
Ossification. U2,
Here or fluid?
fluid.
Fluid.
Why fluid? Not atelectasis. Or maybe pneumoectomy.
For atelectasis, you say that we will see shadow or border, no?
If the red one is totally atelectatic, how would you differentiate whether it is atelectasis or pleural effusion?
Shrinking.
Okay, we have filled here with fluid, right?
Mm-hmm.
Mediastinum would be shifted to the contralateral side. When we have atelectasis, it would be empty space, right? And the mediastinum would be shifted toward the atelectatic side.
Yes.
So here, the mediastinum structures, such as the bronchus, the heart, are shifted contralaterally. It means this is fluid and not atelectasis. If the mediastinum is shifted toward to the affected side, that would be atelectasis. So here we have left hemithorax, which is completely opacified, and there is a shift of the mobile mediastinal structures, such as the trachea and the heart, away from the site of the effusion. What can you see on CT image? Which window is it?
Again, lung window.
Huh? you see the same lump here as here? It is not lump window.
Mm.
Soft tissue window. This is soft tissue window. What can you see here?
No, I guess that is atelectasis.
Which one?
This.
This
Above
one?
this.
This one?
Mm-hmm.
This one?
Huh?
This is atelectatic lump.
And that is heart?
This is heart.
Huh?
What is this?
And how is it happening? At heart level, you will have you see liver. Right side liver. Left side liver. It might be diaphragm only.
Do these two have the same density?
No.
What does this case?
There.
You can see horizontal line between them.
What?
Horizontal line separating the
Lung.
different
It is lung.
densities.
The other one is fluid above the diaphragm.
That is lung only.
This is fluid,
Uh-huh.
but one of them is blood, and one of them is simple fluid. And two different types of fluids is visible in this case. So this is the blood,
Blood.
and the upper one is
Fluid. ये करो बताओ atelectasis.
which one is atelectasis, which one is pleural effusion.
This is left side. This is right side. Huh? Okay. So the that left side. Left side will be atelectasis.
That one is atelectasis.
Huh?
Why?
Right, no? It is right.
Why?
That heart is shifted there.
Shifted
And
forward to the ossification or contrary?
contra.
So,
Pleural effusion. आयच्या गावात.
and the first one or right?
Atelectasis. Okay. Tumors.
Adhesions in the pleural space cause most often by aortic infection or hemothorax may limit the normal mobility of a pleural effusion so that it remains in the same location no matter what position the patient assumes. So pseudotumors, also called vanishing tumors, are sharply marginated collections of pleural fluid contained either between the layers of an interlobar pulmonary fissure or in a subpleural location just beneath the fissure. And they are translates that almost always occur in patients with congestive heart failure. The imaging findings of a pseudotumor are characteristic, so they should not be mistaken for an actual tumor from which they derive their name. They are lentiform or lenticular in shape,
Continue.
and mostly they occur in the minor fissure in 75% of cases, and frequently they have pointed ends on each side where they insnate into the fissure, much like the shape of a lemon. And they do not tend to flow freely with a change in patient positioning. So they disappear when the underlying condition, usually congestive heart failure, is treated, but they tend to recur in the same location each time the patient's failure recurs. Lemon shape, minor
Fissure.
fissure. So there's this fissure of pseudotumor. And this one again
Look at it.
is about the minor
And
fissure,
fissure.
but that is locally local pleural effusion. Hydropneumothorax. The presence of both air in the pleural space, which is pneumothorax,
Mm-hmm.
and abnormal amount of fluid in the pleural space, which is pleural effusion or hydrothorax, is called hydropneumothorax.
Pneumothorax.
So some of the more common causes of hydropneumothorax are trauma, surgery, or recent thoracentesis, to remove pleural fluid in which air enters the pleural space. Unlike pleural effusion alone, where we see meniscoid shape, meniscoid sign,
Yes.
sign,
Mm-hmm.
here we will see this horizontal line, air above, and
Fluid below.
And
Sense.
lastly, pulmonary lucencies.
Yes.
Radiologists use many terms to describe areas of deep intensity or lucencies within the lung, like cysts, cavity, hematocellular, emphysema, myocardum, and so on. And many of these terms are based on the pathogenesis of the abdomen. This makes it difficult to use these terms since in many cases when we describe a chest x-ray, we are trying to figure out what the pathology could be. A more practical approach is to describe areas of decreased density in the lung as cavity, which is lucency with a thick wall, cyst, which is lucency with a thin wall, and emphysema, lucencies without visible walls. Thick wall, cavity,
Mm-hmm.
thin wall, cyst,
Yes.
no visible wall, emphysema.
Emphysema.
And these are the city patterns of lung
Honeycomb.
diseases. Most of them we have already
Yes,
discussed.
honeycomb is
Honeycomb, cystic
cystic
medullary
medullary.
arteriole,
Ground
we
glass.
have not discussed today.
Mosaic.